Good morning. Thank you very much for the invitation to present this difficult topic. I have no disclosures. And it was first in 1967 that Roberts and Morrow reported the first case of AV disruption following mitral valve replacement. And this author in their article mentioned that the removal of a large deposit of calcium which had extended from the mitral leaflets through the annulus into the left ventricular myocardium caused the separation of the left atrium from the left ventricle. On the left side of this image, you can see the left atrium and the left ventricle posterior papillary muscle, posterior leaflet, which is calcified with extension to the annulus, and the removal has caused the disruptions. 2 years later, at the International Valve Symposium, a series of patients were presented in 1969 with false aneurysm of the AV groove following mitral valve surgery, and the first preventive measurements were presented. Similarly, in these cases, the posterior leaflet was calcified and entirely removed, and later on, these patients developed this false aneurysm. However, in this case, all these patients survived. And the author concluded, based on the prior Lillehei work, that the serious complication has been avoided by leaving the mural leaflet intact and suturing the prosthesis to it. So even today, when you do mitral valve replacement, this is very important to leave the posterior leaflet, or at least to provide some support to the posterior part of the annulus. I have included the closing statement of Danton Cooley, who was the chairman of this meeting, at the end of this presentation, which is very revealing. And he mentioned that extensive calcification may present an insurmountable problem in some patients with multivalvular heart disease. We have utilized cardiac transplantation in one patient with triple valve disease. So heart surgeons have been dealing with the problem of annular calcifications and AV ruptures since early ages of mitral valve replacement, and even today that remains extremely challenging. So let's look at some of the literature about this topic. The incidence is estimated between 0.2 to 2%. However, the distribution is not linearized and varies according to the age, the etiology of mitral valve disease, and also the type of surgery that you perform, with valve replacement having a higher incidence than valve repair. However, when these complications occurs, it has an extremely high perioperative mortality. So the key in this area is the prevention, and in order to succeed in that area, you have to focus on your patient selections and your operative strategy and techniques. So when you talk about the risk factors, they can be divided in major and minor risk factors. And among them, in terms of patient's profile, you have age, and elderly are at higher risk of AV disruption following mitral valve surgery, particularly above the age of 80. It has been suggested females are at higher risk, and chronic renal failure and end-stage renal failure dialysis are markers for annular calcifications and MAG. Obviously, multiple reoperations are strong risk factors for AV disruptions. When you can look at the etiology, if you do valve replacement, following valve replacement, you can have AV disruption regarding the etiology. But here I have mentioned the etiology because, at the exception of endocarditis, we are dealing with the issues of calcification, and the pattern of calcifications according to the etiology is different. In patients with rheumatic heart disease, usually the calcification starts at the leaflet with commissural involvement, and the annular calcification is very late. Degenerative disease, as Jill Dreyfus mentioned yesterday, the annular calcification in these patients is encapsulated within a fibrous sheath. So the fibrous sheath can be used to find a plane of dissection, and eventually, if you proceed with the calcifications in this subset of the patient, is a quite safe procedure. Mitral annular calcifications is a different subset. This is what we see in terms of MAC in elderly patients. The calcification is more extensive with deep ventricular extensions. And the final group that we see a little bit more frequently are radiation-induced MAC, and these patients actually, when they present with MAC, have a significant associated other valvular disease and coronary artery disease, and often also some degrees of calcification of the ascending aorta. In terms of anatomic consideration, what is important is the extent of annular calcifications or annular abscess in the setting of endocarditis. We usually divide them into two groups, localized to one segment, extensive 2 segments, and 3 segments, or commissure to commissure or circumferential. The ventricular extension is very important, and other factors such as a small left ventricle for patients with rheumatic mitral stenosis and what you can discover in the OR, such as fragile tissue. So if you take into consideration all these risk factors, I have included the major risk factors. You can develop actually a risk stratification, which is quite simple, into low risk, intermediate risk, and high risk, into consideration age, which below the age of 60 is low risk, as the case that Dr. Dreyfus presented yesterday. Patients above the age of 80 are a high risk group of patients. Annular calcification, if it's localized to one segment or two segments, the risk is quite low. If it's more extensive, your risk increases. The most important thing is the ventricular extension. If the ventricular extension is more than 1 centimeter, I think you're at high risk of having major complications. And in terms of reoperations, if you are having a third reoperations or more, you are at a significant risk of having major issues. So I think when you're on the left side of this spectrum, you're a good surgical candidate. But once you get to the right side of this spectrum, particularly if you have more than 2 elements in the high risk group of patients, you have to be very careful with your operative strategy. And in terms of operative strategy, there are 3 options for it. Either you do conventional surgery or transcatheter therapy or conservative therapy. And these topics were mostly covered yesterday with the conventional surgery, where you can proceed with respecting the calcium or proceed with partial decalcifications or complete decalcification with annular reconstruction using the compression suture technique or pericardial patch, or the transcatheter therapy with valve in valve, valve in MAC, or valve in ring. The best results are obtained in the valve-in-valve patients that you can use for patients who have multiple reoperations after implantation of the bioprosthetic valve. The results of valve in MAC are quite disappointing with an operative mortality, which is in average about 40%, and this is actually an emerging technology which will improve within the next few years. This is the end of my slide, and thank you.